Hello, everyone, and welcome to the Trauma-Informed Care Training. This is a training for all isolation, quarantine, and ACRC staff. My name is Ash Warren, and I am a licensed clinical social worker in the state of Washington. I currently work for King County in the Behavioral Health and Recovery Division as the Assisted Outpatient Treatment Coordinator, which oversees all least restrictive court orders for folks who've been involuntarily committed to the psych hospital. In my prior life, I worked for almost 2 decades with folks who have co-occurring disorders in crisis and generally homeless. So I'm going to tell you some stories about the folks I've had the opportunity to work alongside for those years during this presentation. So I recognize it's weird to have a recorded presentation you're watching somewhere on your computer. I've actually never done a recorded presentation. I realize now that I've tested this 1,000 times that I really do get a lot of energy from the crowd and from questions. So I'm sorry we can't be together in person, but I'm hoping that this is helpful for your work. All of these slides will be available. I will have contact information at the end for myself and for Jamie Lee, who is going to help me send out slides and any handouts of slides that are hard to see. Okay, let's get started. Here's what I hope to cover today. So what is trauma? How does it function both in the body, spirit, and mind? What is trauma-informed care? Tips and tools for approaching things from a trauma-aware lens. And then we're going to talk about secondary trauma and self-care. Okay. Boop. All right, what is trauma? Trauma, we often think about as single event trauma. That's the one we know a lot about in our work and is on TV and things like that. So that could be a sexual assault. That could be somebody who went through Hurricane Katrina. That could be dealing with a death. That could be a major car accident. So these are single events that are traumatic. But what I want to spend most of our time talking about today is complex prolonged trauma, which is the more common version of trauma that we think about less. So this is trauma that happens in multiple events over time, not just a single event. And then I want to make a note that interpersonal violence or a violation, especially at the hands of an authority figure, is especially damaging. So when we think about childhood sexual assault, because that there is a trusted figure there, that makes it a particular damaging event. Or we think about folks who have been incarcerated when they have been traumatized or taken advantage of by folks in power there, say guards. Those can be really, really traumatic events. So there are a lot of different versions of trauma, and we often are only told about sort of present day trauma, which is the bottom bullet there. So present day trauma is what vulnerabilities people are dealing with daily, like in this moment. But cultural trauma is the first one I want to talk about, and that is the attack on the fabric of a society, affecting the essence of the community and all of its members. So racism, structural racism, is a cultural trauma. Thinking about, Native American folks who have been subjugated to reservations and boarding schools. So traumas that have been inflicted on an entire group of folks that has consequences for each part of that. Historical trauma, boarding schools for Native American folks, where we essentially took Native American folks away from their community and put them in boarding schools to teach them the white way of being, disconnected them from their culture. Slavery is a big historical trauma. So this is a cumulative exposure to traumatic events that affects an individual, but continues to affect subsequent generations. So thinking about any sort of massive, the Holocaust, where there is a real disruption, there's a lot of research that talks about how folks pass this down genetically and in the way and culturally this trauma continues to be passed down from each generation. So that's intergenerational trauma. and then present day trauma. So let's think about all of those traumas while we're walking through these slides. So intergenerational trauma, I like this slide because it gave examples. So this context comes a little bit more real. So when we think about, say, Jane on the left, her great-great-grandparents survived the European wars. So the traumas that were passed down through the generations to Jane, many generations, were PTSD, alcoholism, sexual abuse, and emotional aggression. So these were things that happened a long time ago, but are continuing to perpetuate in Jane's life. Ashanti's great-grandparents survived slavery and racial violence in the American South. So things that have been passed down generation by generation because of that massive event were abandonment, domestic violence, low self-esteem, and complex PTSD. Then the last example is Ashok, who survived famine and oppression in British India. So Ashok's great-great-grandparents survived famine and oppression, but poverty, severe anxiety, depression, and shame around gender roles, those are all things that were passed down through these generations. So trauma is a lot more complex than it seems. Okay, let's talk about what does trauma do. So chronic trauma interferes with the neurobiological development and the capacity to integrate sensory, emotional, and cognitive information into a cohesive whole. So it essentially breaks you up into little parts, right? All the pieces and parts of you that were working well together aren't. And developmental trauma sets the stage for an unfocused responses to subsequent stress. So the trauma, when we look at trauma and we think about trauma, we're not necessarily dealing with the initial trauma. We're thinking about how do we respond to all of the stress that comes to people as a result of having trauma. So how do they respond to the next current stress? Because as we know, life is stressful. The next stress is just around the corner, and having trauma and having that happen, particularly complex prolonged trauma, means that the ongoing responses to stress are going to be different. So trauma impacts your feelings and emotions. So you can, lots of anger, lots of questions about self-worth, lots of grief. There's lots of emotional pieces that when trauma happens come. Physical and body responses. So there's lots of research that talks about what trauma does to the body. Lots of chronic pain conditions as a result of unresolved trauma, things like that. Thinking and reasoning function. It is harder to be rational once you have had an incident that has fundamentally shaken your trust. So, and there's lots of ways in which thoughts sort of get grumbled up in your head, and it's hard to sort of plot your way through. Access to family contact or prior level of family support. This is particularly if family was at the root of the trauma, but it's also in situations where somebody has had trauma, a complex trauma or a single event trauma. Family don't know what to do with this, and they don't know what to do with the behaviors that are coming from somebody who's been traumatized, because those behaviors are often really unpleasant. It fundamentally shakes somebody's degree of safety and trust, their actual physical safety, and their emotional safety, and the idea of trusting somebody else after having trust violated is really, really hard to do. So that's something that's broken and needs to be repaired. And then questions about self-worth and where the client has attachment and sense of belonging. So often that's really, really ruptured. People don't feel connected to themselves or to anyone else. So when we're in trauma, our nervous system goes into survival mode. The ventral vagal complex, our social engagement system, goes offline, and we begin to operate from defense and protection rather than connection. So this is just what is happening in our body. So normally humans are very connective people. We need to live within a community, within a tribe. We need to feel connected. Once there has been a trauma that has set in, we move towards defense and protection. Our animal instinct is to survive, and so if connecting to people is the thing that harmed us, we would not reach for connection. We're going to live from a place of defense and protection. So often when people are being quite aggressive, throwing things, yelling, they're trying to defend themselves. They're trying to figure out how to get you to go away. They're not trying to figure out how to connect with you. So one of the most important books on trauma is called The Body Keeps the Score. And Bessel talks about certain preconditions that move a stressful event or traumatic event into PTSD. So we're going to talk through what those are. So preconditions for trauma. The first one, so these are things that if a stressful situation happens to somebody who has already had a traumatic event or complex trauma throughout their lives, one of these things is going to be missing, and it makes it more likely that they'll walk away with PTSD. So trauma creates a lack of predictability. So in their before life, there was predictability, or for folks who've had this intergenerational historical trauma, there often isn't any predictability to speak of. But that lack of predictability makes it hard to function, and it makes it hard to respond to the current stressor. Immobility, so this is talking about that fight, flight, or freeze, what happens in our body when the cortisol starts coursing through and we need to figure out how to survive. That immobility sticks with us and it makes it hard to sort of process and move forward. Loss of connection, which we talked about before, being feeling outside of society or connection. Numbing out and spacing out, this is what we do when there's things that are unpleasant we don't want to deal with. It is a great coping mechanism if you can't sort of stay in your body and your mind to deal with the trauma that's present or the stress that's present. Loss of sequence of time, loss of sense of time and sequence. So there's lots of when you think about asking somebody, tell me what happened on that day, describe that to me, give me a timeline, it's very hard for folks to say, well, this happened first and this happened, then this happened, and it was this time of day. That's not somebody lying. That's actually what happens is that we sort of lose that connection. And then there's the obvious loss of safety. So when somebody is moving from a place of feeling unsafe, it is hard for them to sort of calm down and use their rational brain. And then loss of sense of purpose. So as humans, when we lose our sense of purpose, that can be a very bad thing. So repetitive or prolonged stress and trauma, this is what it does in your body. So it increases your adrenaline and cortisol release. It suppresses your digestive system. That's so if you're running from something and you can't get to a food source, you're going to stay alive. Increased heart rate and blood pressure, so you can move faster, and suppression of your immune system. So if you think about this, these systems on high alert at all times, this increases your risk of future health conditions pretty severely. So the traditional approach to trauma, and this is what happens in a lot of medical establishments today, and a lot of people work from this sort of belief, is that people who are traumatized are sick and bad. Their behaviors are bad, they're unappreciative, they're jerks. Trauma theory suggests that people aren't in fact sick or bad, but they are injured. So thinking about trauma as an injury as opposed to a personality flaw. So I want you to imagine a place. So one of the things I want you to take away from this presentation, if you sort of forget all the rest of it, is when somebody is in front of you or on the phone or somewhere and they're being really unpleasant and you want to write them off and walk away, instead of asking, what is wrong with that person? What is wrong with you? I want you to ask, I wonder what happened to you. So if we can just do that, if we can just take a minute to think, something happened to this person that they're responding in this way. Normal people don't respond in this way, and leave the possibility that something happened to them prior to them interacting with you, I think we're going to get pretty far. The second thing is that we need to understand that past traumas can be triggered by experiences in the present. So things come up a particular smell, a particular visual, somebody says something that triggers a response that to us feels totally bizarre, totally overblown, like what is going on? And often that is a response to a past trauma that we usually don't even know about. We need to be committed to supporting people as they heal and grow, and we need to believe that people do heal, because they do. And we want to function in a way that leaves people feeling edified. So I love this quote. I think about this quote a lot particularly when I'm in care conferences with other staff members and we're trying to figure out, like, what is the deal? If a person's behavior doesn't make sense to you, it's because you are missing part of their context. So it doesn't make you a bad clinician. It doesn't make them a bad human. It's just you don't have the whole story. And doing crisis work for years and years and years, I realized pretty quickly I was not going to get the whole story. So you need to figure out how to get comfortable with the idea that you only got the piece of the puzzle that's directly in front of you, and you're not going to get the whole story. But leaving that possibility that there is a story that exists that you might be missing creates this space of being able to be compassionate and empathetic. So let's talk about what trauma-informed care offers. So trauma-informed care works, right? So the first one is improved our desired outcomes. So it's just better care. It helps people heal. There's lots and lots of research about just changing the way we enter this work and frame this work, and using these few skills that I'm going to teach you really dramatically improves the outcomes. And then it supports trauma recovery by reducing re-traumatization. So why would we want to do the same thing that happened to people over and over? We can do something different, and we should do something different for the fact that we shouldn't re-traumatize people. And there's, in fact, an opportunity to provide a corrective emotional experience. So if we do something fundamentally different than has happened to them in the past, they can actually walk away with a corrective emotional experience. So a good example of this is I had a client who I worked with for 6 months before he would talk to me. Every single time I went to go speak with him, he would literally growl at me to get me to go away. And every time I just said, I'm here, let me know when you need me, hope you have a good day, and walked away. 6 months in, when he finally, had a rough enough day that he needed something, he finally came to my office and he sat down and, demanded what he needed. And I don't, in fact, remember what he needed, but, I sort of sat there and I inquired and I said, I'm so glad you're here. Because I was glad that he finally made that connection. And I asked, why now? And he said, I've been watching you and you keep showing up every single day in this terrible environment. And I don't know, I just need this thing so bad. I don't trust you, but I need you to help me. And so I asked him, I said, how many social workers have you had before me? I'm guessing this is probably not your first entrance into the social service system, because I was working at 1811 Eastlake at the time, which is for folks who use alcohol chronically and often have been in the system a very long time. And he said, well, let me think about that. I was a foster kid starting at age 10, so I had social workers there. Every few years, a few times a year, in fact, they'd cycle through. And then became homeless as a young adult, and so I had, folks there. And then I went into the military, but I got kicked out, and so I had some social workers after that. I spent some time incarcerated. So as this guy was talking, I just sat there and I just made hatch marks of every sort of social worker he talked about, and then I counted them up, and this guy was 46, 47, and by the time he had sat in my office, he had seen 53 social workers, 53 people that claim to have the profession that I have. So why would he trust me? Because those other folks that came before did not do what he needed them to do, and they didn't treat him in a way that he appreciated. He felt like he had no power. So why would he trust me? So all of that 6 months of grumbling made a whole bunch of sense. And so what I did, the work that I did with him, was not particularly radical. It's what I'm going to talk to you about today. And then the last reason that we should use trauma-informed care is that it decreases our own vicarious trauma and compassion fatigue. So we're not we're not experiencing firsthand trauma at work, I hope. Some of us might have had that happen, but that's not our everyday experience. But our everyday experience is dealing with other people's trauma. We call that vicarious trauma. So that's the stuff that we're witnessing and holding for people, which leads to compassion fatigue. At some point, it's hard to care because you're out of juice. So trauma-informed care decreases that. Okay, the core principles of trauma-informed care. So let's go over these, and then I also have, after this, the substance abuse and mental health version of these, which are similar. So in order to provide trauma-informed care, the first starts with awareness. So that's a lot of the talk of pausing to think, I wonder what happened to somebody. Being curious about people's behavior, not just shutting down when they're rude or mean. So we need to understand what trauma is, how does it function, and then some ways of seeing it in somebody or being curious about that. We also need to help folks understand when their trauma is showing up. So that's another way we can help not only ourselves as clinicians be aware, but clients be aware. The next part is empowerment. So a lot of what's at the root of trauma is that people have had their power taken away from them, often in really violent ways. So part of creating that corrective emotional experience is helping folks take their power back. And often that's in very little ways, in small ways and in big ways, but thinking about what are some ways in which I can give this client, this guest, their power back. We got to get creative in spaces like I&Q where we're delivering all their meals. They don't see us in person, but there are some ways to do that. Like if you call somebody on the phone to check in with them, just asking, is now a good time or can I call you back later? That simple gesture of your time is valuable, not just mine, you're not just working on my clock, means a lot, goes a long way. So the next is safety, thinking about physically safe spaces. So folks who are chronically homeless and are trying to figure out how to move from place to place each night. Once we get physical safety, Maslow's hierarchy of needs suggests we can move on to other things. But this is also talking about emotional safety. So are we emotionally safe people for clients to reach out to? Do we have our stuff together? Do we do our own work? Trustworthiness. So this is basically you do what you say you're going to do. So I feel like 90% of the job of being a social worker is being asked questions that you have no idea the answer to. And the best social workers in the world don't just make it up. What you do is say, I have no idea, but I am going to figure out who does, and I will get back to you. So the trustworthiness comes into actually doing the research and getting back to the person. So do what you say you're going to do. So collaboration, when we actually work together with both the client and with other care providers, we are able to expand our skills. So working together in a collaborative way makes it so a client has an entire family of trust as opposed to just one person they can go to. And me as a social worker, when I am collaborating with a nurse or I'm collaborating with a doctor or a case manager, I've increased what I can do for that client because all of those folks can bring their skills to bear. And then choice. Choice is a huge one. So figuring out ways that clients get to have choice in their interactions with you. So say your job is to deliver them their psych meds, and if they're off their psych meds, things don't go well. And generally, you want to take your meds around the same time of day, and us as busy people have times we'd like to give it to you because we need to move on to the next task. But what if what if the person wasn't ready right now? Can they come back in 5 minutes? Is there some other way that they can have some choice about how they do that exact same thing? Okay, so SAMHSA is this is the federal overseeing body of addiction and mental health services. So they've covered a bunch that are in the former slide, but they added a few. So with trustworthiness, they add transparency. So it's important to to be able to be transparent and tell clients what you're doing and why you're doing it to the degree that that's appropriate. So we don't, that's a way to build trust. Peer support is the idea that we really center folks who have had similar experiences, who had lived experiences in our work, that we have them be meaningful contributors and creators of systems where we're working with clients. So peer support is people who have lived experience with mental health or chemical dependency, being workers in the system and really helping design the system that creates a place that is much more trauma informed, because if you have folks on your team who have been through similar things and we continue to act in ways that are re-traumatizing, we're less likely to do that if somebody's able to tell us, hey, whoa, that's a little, you got a blind spot there. And in the work that they do, they can do a lot more disclosure in ways that we can't as clinicians. Collaboration, we talked about, but mutuality is this idea that we do something. One, we recognize that we have power over clients, systems have power over clients, and that we do whatever we can to flatten that power, to come to a place where clients really have voice and choice, which is the next one. So are we asking clients what they want? Are we listening to them? Are we making decisions based on their needs? And are we creating choices? And when they're trying to create their own choices, are we listening to those? And then you really do need to understand cultural, historical, and gender issues when you're thinking about trauma. So trauma does not exist without culture. The cultural pieces, the oppression, the racism, the violence, all are the air that we breathe and the place that we live. And if we don't understand those pieces, we're not going to ever understand somebody's experience and the trauma they're going through. So as a social worker, it's important to me that we think not only about our individual interactions with clients, but that we think about the bigger system. So in social work, we call this macro practice. So these are the 4 R's of trauma-informed program, organization, or systems. So if you had a system, a whole organization, all of the INQs, ACRCs were trauma-informed, we would do these things. So we would realize widespread impact of trauma and understand the potential paths for recovery. We would recognize signs and symptoms of trauma in clients, families, staff, and others involved in the system. We would respond by fully integrating knowledge about trauma into policies, procedures, and practices. And we would seek to actively resist re-traumatization. So this slide is a little bit hard to see, and as I said, I'm going to get all the slides to you so you'll be able to look at this more fully. But trauma-informed care recognizes that traumatic experiences terrify, overwhelm, and violate the individual. Trauma-informed care is a commitment not to repeat these experiences in whatever way possible, and to restore a sense of safety, power, and worth. So the foundation of trauma-informed care are twofold. One is the commitment to trauma awareness, which is what we've been talking about so far, and then understanding the impact of historical trauma and oppression. So once those two pieces are there, you can then look at these other subcategories and think about, okay, how do I create a safe context? So I can create that through physical safety, trustworthiness, clear and consistent boundaries. They don't shift, they don't change. There's an explanation of why we have those boundaries. Transparency, predictability. So we've got a schedule, we've got a way we flow, and choice. It restores power through choice, empowerment, using the strengths perspective, which I'm going to talk about a little bit farther in future slides. But the strengths perspective, just to take a little minute here, instead of looking for what's wrong with somebody, we look for what's right. We look for what strengths they have, and we build based on that. So if we can really move from a deficit-based thinking to a strength-based thinking, not only will the clients respond to us better because we see their worth, we will also have most of the ideas about what's going to help them heal from them. They already have that inside of them. Our job is to help them discover those and to leverage those. You can't do that if you're looking at just what's wrong with people. And then skill building. So the skills we're going to talk about today, you've got to learn them and then try them and screw them up and try them again and keep going. So we need to hear and see things differently, but we got to give it a try. And then it builds self-worth through relationships, respect, compassion, acceptance and non-judgment, mutuality, and collaboration. So the foundation of our work with people is built on relationships. And if you think about trauma as a disease of broken relationships, thinking about how do we repair and how do we create true relationships, and that we've got to do whatever we can to accept people in this moment and accept their past and actually come from a place that's not judgmental. So when you hear yourself grumbling about what a jerk this client is, taking a breath and thinking, I wonder what happened to them, and trying to get to a place of non-judgment so you can move forward. Just so you know, if you're judging a client, they can see it 1,000 miles away, even if they're distracted by the voices in their head and everything else that's going on. People can sense it and feel it. So even if we think we're just having our internal monologue, it's often clients with severe mental illness are much better at paying attention to our body language than our words, because our words often are confusing or get jumbled up. Okay, so let's talk about some ways that we can counteract trauma. So this is back to Bessel's The Body Keeps the Score. So he talked about these sort of preconditions. So I'm going to talk about these again, but what we can do about it. So when trauma sets in, predictability is out the window. So we can create some gentle schedules, right? We can, I do a lot of work with clients to say, okay, I know you don't have much going on, but I need you to try to get out of bed at 8 a.m. and brush your teeth. And then, right, we sort of chunk out time of how we're going to spend our day. Because we're learning this about quarantine, is that we're all sitting in our homes with our children and our dogs and our spouses and going nuts because we don't have any schedule which creates boundaries from our home life and our work life. So creating some of those helps quite a bit. Immobility and fight versus flight activated and nowhere to go, so feeling stuck there. So movement and completing concrete tasks. So this is like the old method of like make yourself a to-do list and you've already done 3 of them so you can check them off. So that's real, right? Complete concrete tasks. They don't have to be giant tasks. They have to be something to get you moving. So you think about being stuck. How do you get something unstuck? You fake it till you make it. You start moving somehow. And then movement is actual physical movement. So there's lots of research that says if you're in a traumatized space or you're dealing with stress, figuring out how to move your body. So this doesn't mean you have to take up marathon running, or clients have to take up marathon running. In the quarantine sites, they're stuck in their room, but there's lots of movement that can be created. Can you wash your dishes? Can you stand up to go take out the trash? Can you do some stretching? So figuring out how to get back in your body and to move your body. Connections with others are disrupted during any sort of traumatic event, certainly during the quarantine and COVID-19, we're having a lot of disruptions with connections. So is there a way that people can Zoom or any of the things where we can actually see facial expressions, and then figuring out how do people want to connect? Can you play music together? Can you play cards together online? Is there a way to stay connected to your community even if you can't physically be around them? So lots of ways of thinking for folks who are guests in these quarantine sites. How do we help them stay connected? So numbing out, spacing out, some healthy ways to, there are some healthy ways to numb out, getting lost in a book. And then you can also start practicing some mindfulness and noticing feelings. So helping guests and ourselves notice when feelings are coming up and paying attention to them, taking some time to do deep breaths or guided meditation, sort of whatever that looks like for you. Loss of sense of time or future. So work on being in the present moment and letting go of control. So I have good people in my life that often say you don't have control of that, but you're frantically trying to control it. And we do that when we feel out of control, we feel untethered. And so the only way to sort of combat that is to try to get in the present moment, feel the ground on your feet, take a deep breath and look up and notice where you are, and then figure out what you can let go of. Safety feels threatened. There's lots of things we can do to actually calm our nervous system. A lot of that lives in the mindfulness world, in yoga and movement, in mindfully doing the dishes. So figuring out how to sort of calm down and reset, because if you're feeling really threatened. So this is why if somebody comes to you screaming at you and threatening you, it's not the time to like talk about what happened to them in their childhood or tell them to shut up or do anything. They've got to figure out how to feel safe again. And so helping people calm down and take a pause so they can get back in their body helps a lot. And then loss of sense of purpose. So thinking about what helps people feel meaningful and valued right now. So to the best of your ability and within your given time constraints, which, we all have different skills in this area and we all are busy, there's a few things that we can do. The first way that we provide trauma-informed care is to lose the labels. So we're going to talk about this a little bit farther down, but thinking about how we talk about people and we label people, if we lose those labels, we'll be very far along the path. Let people tell their own story. So ask them questions, be curious. And then if you ask them their story, give them time and space to tell their story. Once you understand people's context and what came before and what they're thinking about now and what strengths they have, it provides your pathway forward, builds that relationship, and sort of sets the groundwork for all the rest of the work you have to do together. Let the person lead. So even if they can't be in control of every single decision, they do need to be in control of what they're going to do with their life. And so you've got to figure out ways to let go of when people want to do something that you don't want them to do. People really need to be in charge of their own lives. And then when you're having these difficult conversations, it's important that we are recognizing the other person's comfort level and that you're recognizing your own comfort level. So when we have difficult conversations, we need to be able to self-soothe and be present. And if you notice that the other person is getting quiet or shying away, it might be time to sort of pause on the pushing. And then you always need to consider the person's perspective from their cultural context. If you don't understand somebody's cultural context, you can ask, you can do your own research. Even if you have a shared, one of your social cultural connections are shared, your social identities. Likely all the rest of them aren't. They have some social identity that you don't share. And so making sure that you're tending to and thinking about all of the different social identities and cultural contexts that people come from. This slide I love. So this is from Tony Oswego. She's a local private therapist. She actually worked for me many years ago at the Crisis Solution Center, and I really appreciate her work. She put together this slide of ways in which you will know that if you're being a trauma-informed therapist. So I know that not everyone who works at the IQ and ACRC sites are therapists. This really is a good slide for any staff. So a trauma-informed staff member won't blame you for what happened to you. So take a pause on that. Let's think about, are there times where you're blaming clients for their circumstances? Where you're blaming them for their behavior? Are there ways, maybe you're blaming them for what happened to them? So are there ways to pause around that? A trauma-informed staff member will help you understand how your emotions, body sensations, thoughts, and actions are connected to what happened to you. So we're not doing trauma therapy at the INQ sites, but we do need to be coming from a trauma-informed lens. So you might not be doing the detailed work of helping people connect all those pieces, but understanding that all of these things are connected, I think, is quite helpful. A trauma-informed therapist will explore with you the impacts of systemic oppression, prejudice, and discrimination. So they're not going to shy away from that. They're going to listen to what you have to say, how the oppression and the discrimination is affecting you, but they're going to be open to exploring what those impacts of this system are. We'll be an ally to marginal communities. So I often say, you know that you're an ally to a particular community if that community thinks that you're an ally, right? You don't get to self-determine you're an ally. So in which ways are you allying for marginalized communities? We'll help you find your strength to cope, soothe, and regulate. So these are the things we need to be doing while we're in a stressful situation. Anyone needs to do in a stressful situation or somebody experiencing trauma. You need to think about how are you going to cope with it, how are you going to soothe your way through it, and how are you going to regulate. A trauma-informed staff member will be trustworthy, transparent, and clear about their boundaries. So are you clear about your boundaries with staff? Are they consistent? Do they make sense? Are you sharing them? We'll collaborate with you and empower you, offer you choices, and respect the ones you make. And most importantly, in a lot of ways, a trauma-informed staff member won't define you by your trauma, but will see you as a whole person. So let's think about some ways that we are seeing people as whole people. So one of the fundamental ways of providing trauma-informed care is to change the way that we think about people, right? So that's what we talked about at the beginning. So people who have been traumatized or people that you're working with, anybody, any human being on the planet can grow and change. They are not permanently damaged with no future, right? So at the moment that you start talking about or thinking about somebody as like a lost cause, you need to pause because every single person has the ability to grow and change. And a note here that growing and changing is at whatever pace they can tolerate, is whatever trajectory they want it to be, and that the final result might not be what you see as successful, because that is all very cultural. They have trauma that's hard to hear, but harder to talk about. They're not making it all up. Right? This is not all manufactured. There is trauma that exists. It might be very unpleasant for us to hear, but it is in fact way harder for folks to talk about it. So often clients don't know that what they're experiencing or they experienced in the past was trauma, or what they experience every single day is trauma. So often they don't have the language for it. But if somebody is going to share with you parts of their trauma, parts of how racism affects them every single day, or how they had this one incident in their past that really sort of defines how they cope, think about that as a gift. They trust you enough to tell you about it, even if it's not coming out in a helpful way for you. People are not attention seeking, they're asking for help. And they may not be asking for help in a way that you like, a way that is polite, a way that is calm, a way that understands that you have other things to do. It might not even consider you. But they're not just attention seeking, they're asking for help. So people need connection, and particularly people who have been traumatized, as we talked about before, that connection has been broken, and they're in this place of protection and defense. They're not in this connection-making space. So people are asking for help. They are not just a bad person or acting out. They are communicating that something is wrong. So something is going wrong for them. So how do we do this in actual language we use? I've heard some of this language at the IQ sites. I hear it in most social service settings. These terms come up, and so I want to challenge them and reframe them to think about how we can use these differently. So the first one is addict. So somebody is not an addict. They are a person who uses substances. Because the word addict means dirty and wrong and morally corrupt. There's so many cultural things we put on that word that it no longer talks about just the fact that it's somebody who uses substances. So if we talk about somebody who uses substances, we should be talking about sort of how much they use and is it putting them in jeopardy, and is there anything we can do around harm reduction, and how do they feel about it, and what strategies we can use. It doesn't say like avoid it totally, but it does say stop calling people addicts. So deficit-based way of talking about somebody is to call them a frequent flyer. So the way that I think about this person is they utilize services and supports when necessary. And the frequent flyer often means they're there a lot, but they probably need to be somewhere a lot. They probably need services a lot. And yes, maybe they don't need to be going to the hospital all the time, but this is a systems issue. We have a broken system where people are showing up in the ER all the time to get their basic care needs met. If we had a different system, people could utilize it differently. If they had access to it, they understood it, if they always had health insurance, those sort of things. So since that's not the case, they're showing up in these places that are, quote, inappropriate. Deficit-based way to talk about somebody's behavior is to call them aggressive or hostile. I want you to really think about them being protective, because that's more accurate. That's actually what they're being, is being protective. And that comes out in ways that we would normally label aggressive or hostile, but what they're trying to do is protect themselves. So let's inquire from that space. It will give us a lot more ideas. People aren't helpless or hopeless. They are, in fact, just unaware of their capabilities and the opportunities that exist. When you are in a place where you're stuck, which happens during trauma, it is really hard to look up or to look internally and to see any sort of strength. That is our job, is to help people become aware of their capabilities and the opportunities. And then another word I hear a lot is runner. So people aren't runners. It's somebody who left before we wanted them to discharge. They left against medical advice, right? Like they left before we wanted them to go because, COVID's not cleared up, or they still had services they need, or whatever the context is. But calling them a runner just defines everything that happened before and in the future as this one thing. They made this one decision. And yes, they made that decision. They left before discharge. But why do we have to label it as a runner? Calling people lazy. People aren't lazy. They're ambivalent, or they're working to build hope. They don't have that hope yet, so they don't know how to move on it. So just labeling somebody lazy keeps them stuck there. People, we see these in medical charts all the time, manipulative. That person is really, really resourceful. So most people, this is the image I sort of think about, most of us can just go down the highway. Most of us want to go down the highway. If we're going from Seattle to Tacoma, the easiest way to get there is to get on I-5 and go south. So if you no longer can access I-5 because you've got a DUI, or you've got to take the bus, or for some reason, right, there's some barrier that's in your way where you can't take the highway, you're going to figure out how to get there on the back roads. And often we get mad at clients for taking the back roads. But the reason that they're doing that is not just to be annoying or be jerks, is because the highway is no longer accessible to them. So when people are manipulating the system, quote, what they're doing is trying to build a different system because the one that currently exists does not work for them. So let's think about that. If somebody is resistant, it means they choose not to, or they're not ready for it, or they're not open to it. Doesn't make them a bad person. They just don't want to. Think about all the times when you were told what you need to do, and we're told what we need to do all the time, and you just say no. Yeah, like you're resistant, quote unquote, but how is that helpful to sort of keep somebody labeled that way? And then thinking about people with co-occurring disorders or mental health or any sort of behavioral health disorder, substance use, they're not suffering with this, they're experiencing it and they're living with it. So how do they live with this in their life, as opposed to how do they, they're constantly suffering with it? Because some people are really thriving and have found recovery around their mental health or their substance abuse, and they're not under this constant suffering. So paying attention to that language, it's very loaded. Abusing the system. I talked about this a little bit earlier. Somebody who's abusing the system is a good self-advocate. They have learned enough about the system to be able to try to advocate for themselves and get what they need, because the system, as we've built it, is not working for people. And then we're looking for weaknesses. Weaknesses really are just barriers to change or needs that somebody has. Okay, so here's another sort of visual of how we do this trauma-informed care work. So space. Allow for the survivor to calm down and take perspective. Trauma survivors often have difficulty regulating emotions and take longer to calm down. So give people the space they need. Predictability. Not everyone loves surprises. So can we be predictable in our work? That will help people stay in a place where they feel safer. Perspective. Be aware when past is intruding into the present. Don't take responsibility for what is not yours. So 99% of the trauma that happened to people or they're experiencing currently has nothing to do with you. And so when I'm in the midst of really starting to give up on clients or they're yelling at me or whatever, I have this mantra that I say in my own head. It's not about you, Ash. It's not about you. Because it isn't. It's about how I respond in this moment. But I wasn't the one who traumatized them. But I can make choices about how I help them moving forward. Support, be kind, loving, and patient, but set really, really good boundaries. Choice, it can be a big trigger when survivor is denied choice and control. Confer and collaborate. Reciprocity, give what you also need to receive, which is listening, empathy, and empowerment. Don't refer to the person's upbringing, issues, behavior, call it for what it is. It's trauma, so that's attribution. So thinking about when we're talking about particular behaviors or problems, let's talk about the trauma. Let's label it trauma. Then that helps us to separate it from the person and it stops becoming this personality issue. And then the last piece is recalibration. So rid overreacting, oversensitive, or over anything from your vocabulary. Right? They're not being too big. So the spiral model, this is talking about first you need to start with people's experiences. You need to understand their experiences, ask about their experiences, or just see what you see in front of you. Look and see if you can find some patterns. Add any new information or this trauma-informed theory here. Practice the skills, strategize and plan for action, and then act. Try it. Give this a go. This is a new skill. You're not going to do it right the first time, but I encourage you to take any piece of this presentation that's helpful and give it a go, and keep giving it a go until it's something that's useful for you. So I always like to talk about sort of where does where do we sort of ground it in? Where do these theories come from? So in King County, we have the fundamental components of recovery, which I think speak beautifully to how we need to be providing care for anyone that we're serving. But I think it is particularly a trauma-informed way of looking at our work. So to create a space where recovery exists, we need to help people with self-direction. So they need to lead, control, and find their own path of recovery with providers as partners. Individualized and person-centered. So everyone has a unique path. We support all of those different paths. Empowerment, people choose from a range of options and participate in all decisions affecting their lives. Care should be holistic. Services support the person's whole life. Mental health, substance issues, physical health, spirituality, community, housing, employment, education, creativity, having friends and family support. So thinking about ways that we think about people as whole humans. The recovery is a process. It's a process of growth. It has setbacks, and we learn from our experiences. It's not a straight line for any of us. We need to be strength-based. Services focus on valuing and building on people's strengths, resiliencies, talents, coping skills, and interests. That we center peer support. That's people receiving services help each other on their recovery journeys. Peers can become providers with training. Respect, acceptance, and appreciation for everyone, including protecting individual rights and eliminating discrimination and stigma. Responsibility, everyone has a personal responsibility for their own self-care and recovery. Hope, everyone, their family, friends, providers, and others encourage the belief that people can and do recover. I see people recovering all the time. And then the last one King County added was resiliency. So this is what we call the +1. Resiliency is this idea that people are able to bounce back after difficult experiences. Everyone has the ability to develop resiliency. There's lots of research on this about grit and resiliency that really talks about the people who are really successful are folks who have in fact had setbacks but have been able to bounce back, and sort of what needs to exist for people to be resilient. And they're the exact same things I'm talking about today. I always offer this for every time I do a crisis training or I talk about trauma-informed care or really any social service care. This is a very helpful thing to me at the Crisis Solution Center. We have it posted all over all the walls. The acronym is HALT. Are you hungry, angry, lonely, tired? Go take care of that first. Right now. So take care of those things first before you do anything else. So anyone who's had an infant in their life knows there's really only a few things that they're crying about because they can't tell you. It's this list. That's the same thing for every single human. This is the list. This is possibly what's wrong. So if somebody is experiencing stress or having a trauma reaction, one of these things is probably going on if they're really, really escalated. So thinking about hungry, angry, lonely, tired. When I was on the mobile crisis team, I would be like, the first few hours of my shift, I was really compassionate. I was really empathetic. I've got lots of time and space. I was great with all different kinds of clients. I was awesome with my coworkers. And then about 1 o'clock in the afternoon would hit, and I would start rushing through the outreaches. I would start getting really grumbly with my partner. I would it just was a pain in the butt. And finally, one of my mobile crisis team partners handed me a granola bar. And I was like, I'm not hungry. And I sort of barked at her. And she was like, just eat the damn granola bar. And I did. And I felt better. And I was in such a state that I didn't recognize my own needs. I was too busy. We had too many calls. There was too many people in crisis. And I wasn't going to pause to go to the bathroom or to eat something. I was in service. I was doing my thing. And so from there on out, I just, in every car I drove, I brought some granola bars with me. And when I felt myself getting short, or if anyone gave me clues, sometimes it's clients, they're like, what's with you? If you have clients giving you feedback, you haven't self-regulated. So I started bringing granola bars with me everywhere I went and managed my own blood sugar. And then I stopped being as much of a jerk. So thinking about how do we provide this space for ourselves and for clients. So do you go to bed on time? Do you have any sort of sleep hygiene schedule? Are you connecting with people? Are you feeling angry a lot? Are you doing something about that? Are you eating at a regular time? So do any of these feel familiar to you? Do you commit to projects that you should probably say no to? Have you ever felt like you could never work hard enough? Do you want to automatically say no to everything? So there's a whole list of these. So if these things are coming up for you, you might be experiencing burnout. This shows up in people's lives in a whole bunch of different ways, but some of them are feeling helpless and hopeless, feeling like you can't do enough, feeling very grandiose, hypervigilant and fearful. Your creativity's gone. You have a difficulty embracing complexity. Everything needs to be black and white and simple. That is often a good sign that burnout is setting in. You minimize other people's pain or your own pain. Feelings tired, like really tired, like bone, heart, and soul tired. Avoiding things, disassociating, feeling numb, taking things personally. Feeling guilty in moments of joy. Feeling cynical or snarky, overusing alcohol and other drugs. So this slide, I like how the slide looks, but I'm going to move to the next slide so I can actually talk about these pieces because I typed them out. So when experiencing overwhelm and trauma, so these are a list of things that could be happening either for your clients who are experiencing trauma or for you who are feeling overwhelmed and are having some secondary trauma. These come from Laura Lipinski Vandernoot, who wrote the book Trauma Stewardship. She writes a book about secondary trauma that is excellent. She's a local Seattle resource. I encourage you to look up some of her stuff. So when experiencing overwhelm and trauma, anger and cynicism sets in. You have a lack of awe. You feel grandiose. You have a negative bias and not assume well of others. You have a difficulty empathizing, minimizing, and numbing. You're pulled towards confirmation bias and away from critical thinking, right? You just everything that you see is exactly what you think you're going to see. That's confirmation bias. It's like, of course, that person's a jerk. Here's all the evidence I have to prove that. So if any of these things are coming up for you, you might be experiencing secondary trauma, you might be experiencing some burnout. If you are seeing any of these things in your clients, they might be experiencing overwhelm or trauma. These are some of the clues, some of the signs that things are off. So there's things you can do about it. Like stress reduction does not have to be fancy. This is sort of like I have little kids and this is sort of their list every day. They've got to do these things and I make this list. I have this little picture on my computer of like these are the things I need to do every day too. So sleeping, connecting, eating food, drinking water, going to nature, moving your body. The days you feel really crappy, just like pick one of these things to try to do. But if you're doing these on a regular basis, you're taking care of your facility and you're not going to burn out quite as quick. So this is the Trauma Stewardship's Tiny Survival Guide. We will put this as a handout too. So here are some ways where if you're doing these things or you're feeling overwhelmed, you can start doing some of these things to bring yourself back to yourself. Spend some time with animals, clarify your intentions, be realistic, go outside, protect your mornings, nurture gratitude. So research actually shows that gratitude's a real thing. If you cultivate gratitude, if you literally every day spend a second saying one or two things you're grateful for. This is a picture of a gratitude journal. Some people write it down. I'm not a writer. But I do every single day say something that I'm grateful for. That helps you reframe. It's the same way that you can move from deficit-based thinking to strength-based thinking. You can actually train yourself to think this way. So gratitude's real. And then this is just a list I put in here if you're looking at the slides in the future about some ideas of things, because often we feel stuck or we feel overwhelmed. So these are some things you can do to get going. Okay, so the summary of this presentation, what I want you to take away is that trauma comes in many forms. It's not just that single event. It can be complex, prolonged trauma. Notice the signs that I have a bunch of different slides about what happens to people when they're experiencing trauma. Notice some of those signs and get curious. Start thinking about, I wonder what happened to somebody as opposed to them being wrong or bad or sick. Use the core principles we talked about today, awareness, trustworthiness, develop those, use those skills. Pay attention to your language. It's going to change the way you think about people and change the way you treat people. Notice burnout in yourself and actually choose to engage in self-care. I am really grateful you guys decided to spend the time with me. I know you were probably voluntold to do this training, but I do appreciate it. My name is Ash Warren. There is my contact information. If you would like a copy of the slides and the handouts, please contact Jamie Lee with King County. Her contact information is there, and she can get you all these resources. I hope you are safe. I hope you are well. I hope this was a useful time we spent together, and I appreciate you taking the time.